Hi, my name is Saad. I'm an ophthalmology resident doctor here in the UK. Today, I will take you through the topic of bacterial keratitis. So you're in clinic, you're an ophthalmology doctor, and a young woman about 24 years of age walks into clinic holding her right eye. She has a tissue in her hand as well, which she's holding to her face. She turns her face away from you, away from the slit lamp, and she sits down. And when you reach for the pen torch, she flinches away. She tells you that it started yesterday. The eye was quite red, it was quite painful, and it was watering quite a lot. And as of this morning, everything on that side of her vision has gone quite misty as well. And you finally decide to actually get her to move her hand, and this is what is shown to you. You see that the right eye is quite red and the left eye is quite white, which means that most likely the problem is with the patient's right eye, and this is where you have to focus your attention. And in the mirror, when she looks at her eye, she can also see a white spot on the clear part of her eye. I mean, the title's already told you where we are going with this. This is a case of a bacterial corneal infection, bacterial keratitis. But here's the question I want you looking at instead. If she had walked in with no title above her head, like in this video, it's just a painful red watery eye in someone of her age with a white spot on her cornea, what are you thinking about? Well, one thing obviously you want to think about is in history, you want to know if she's wearing contact lenses. The history will start narrowing down your possible causes in this situation immediately. You decide to ask her whether she wears contact lenses, and she says, well, she does. She wears monthly contact lenses, which means that she would get these contact lenses once and she would wear them for a month. And she admits that unfortunately she had also been sleeping in them, and over the last 2 nights she had kept them in, and when the eye started becoming a bit gritty, she had decided to take them out. Now, there are a few causes that I want you to think of in this case. As soon as the patient has given the history that she has and the gears start turning in your head, firstly, you think that this is most likely to be an infective cause of a red eye. And so if there's one thing you take away from this case, take this. How do you tell your barn door bacterial keratitis apart from its mimics? Generally, pain that is quite out of proportion to what you can actually see in a lens wearer who's been near water as well. That's Acanthamoeba until proven otherwise. So what you're looking for is a ring-shaped infiltrate on the cornea, like in this picture where you see here is a ring infiltrate, and you can almost see this haze on the cornea and with quite a red eye. Next, if the patient has a history of being exposed to some soil or a branch or vegetable matter into the eye, and you find on the cornea an infiltrate with feathery, ill-defined edges, possibly a few satellite lesions here and there as well, that is likely to be fungal. Like in this picture, where you can see the edges of the actual infiltrate are quite ill-defined with feathery margins. Well, what about an eye that's been here before? It has had recurrent episodes, reduced corneal sensation, and a branching dendritic sort of a corneal surface lesion when you stain it with fluorescein. Now in this case, I want you to think of herpes simplex keratitis. And what does that look like? So in this photo, you can see here is this branching lesion, and you can see the terminal bulbs at the end of these dendrites, and these indicate to you this is most likely to be a herpetic lesion. Moving on to the next one, what about an infiltrate which is sitting right at the edge of the cornea, and there is a clear gap between the infiltrate and the rim of the cornea, which is the limbus. What you also notice is a bit of meibomian gland disease or blepharitis on the lid margin. These infiltrates are likely to be sterile rather than infective. Have a look at this picture. So here you're seeing these infiltrates right here, and you can see that there is a clear zone in the cornea between the infiltrate and the limbus, and that's called limbal sparing, and this is likely to be marginal keratitis. Well, what about bacterial keratitis? Now, bacterial keratitis often presents with almost a central or paracentral infiltrate, a lot of pain, plenty of discharge. And here's what that looks like. So you can see here is your infiltrate with a bit of corneal edema around it, and the infiltrate itself has quite well-defined margins. And that's a few characteristics to remember for these various causes of an infiltrate on the cornea. So that's what I'm worried about in this situation, and the eye is going to tell me now which one of these options is actually happening in our patient. So now what you decide to do is you decide to take out your slit lamp and actually start examining the eye. And here's what you find. So this image is what you see. Okay, so the first thing that hits you immediately is there's so much white going on here. This is the infiltrate itself that we are worried about, along with some corneal edema around the infiltrate itself. And what is this infiltrate? This is the stroma packed with inflammatory cells, organisms. It's quite central, which means that this is going to impact the patient's vision. Now look just underneath it. You have this sort of a boat-like collection which is happening, which is called the hypopyon. Now this collection is a combination of white cells, inflammatory cells, pulled by gravity. And a point worth noting, in this situation, in this keratitis, that hypopyon is sterile. It is not full of the bugs themselves. It is the eye's reaction to those bugs. It is all walled off by the back of the cornea. So unless the cornea actually perforates, this collection remains sterile. You can see that the lid appears quite swollen as well due to the inflammation happening, and the whole eye is quite red as well. So the next step I would do is I would reach for the fluorescein eye drops, which are the orange eye drops we put onto the corneal surface. And here's what you see. What you see is that what looked like a white infiltrate, when you stained with some green fluorescein dye, it changed its color to green. What that means is on that particular site, the epithelium of the cornea is broken. It's broken open, and that's your finding. So an infiltrate is inflammation, but an infiltrate with the surface torn open above it, like in this case, that's an ulcer. That's infection, which is eating through the cornea. And that fact does the ruling out for me. So sterile marginal infiltrates sit out at the edge. That's not happening here. It's quite central and looks bacterial to me. Now it could be very well be one of the nastier bugs like Pseudomonas. So it's important that we now go into our investigations to try and narrow down what kind of bug we're dealing with and provide treatment for it. So now pulling all of this together, trying to teach you how the contact lens actually causes this infection, let's try to understand what happened. Well, that's because normally the cornea defends itself. The cornea normally has an intact surface. So let's have a look at this picture. Here is the cornea. At the back of it is the aqueous humor inside the eye, and at the front is a layer of tears. Now normally the intact epithelium and the tears, they come together and they protect the surface of the eye from breaches and infections. The constant flush of tears keeps the bacteria moving along, and normally they cannot get a good hold onto the corneal epithelium. When you sleep in a contact lens, it can starve the surface of the patient's eye for quite a long time. And so the epithelium is not able to get the nutrition that it needs, and it becomes quite rough. And that becomes the doorway for the bacteria to latch onto the cornea and cause the infection that you see. Now, an interesting fact for your exams, there is a tiny club of bacteria that can punch through a perfectly healthy cornea. So these bugs are 1, Neisseria gonorrhea, Neisseria meningitidis, Corynebacterium diphtheriae, Haemophilus influenza. Pseudomonas is also the lens wearer's enemy. It's gram-negative, it's everywhere, and it's quite fast in causing an infection. It can cause the cornea to melt quite fast, and that's exactly why her short history is quite frightening. So what do? If the ulcer is quite significant, it's quite central, it's bigger than 1 millimeter or 2, we have to scrape the cornea. And this corneal investigation is done using these kit that you can see in front of you here. So you'll have the culture plates, you'll have the glass slides, and you can use a needle or a sterile blade to scrape the base and the leading edge of the ulcer. So in this picture, you can see a needle being used to scrape. Make sure to scrape the base of the ulcer along with the actual edge as well. But that does not mean you need to delay the treatment, because that infection still needs empirical treatment while you wait for the actual scrape results to come back. So for this, you need antibiotic. We're going to use antibiotic drops to begin with. Now, there's 2 ways to go about this. The first one is to go with monotherapy. So you could go ahead with intensive fluoroquinolones, hourly monotherapy, or you could go ahead with fortified dual antibiotics, which includes intensive gram-positive and negative cover with something like KEF for the gram-positive, gentamicin for the gram-negative bugs. When do you use either? Well, you can use the intensive fluoroquinolones like ofloxacin or moxifloxacin eye drops every hour if the infection is not too severe that you need to admit the patient, and this is something that the patient can manage by themselves at home. On the other side, choice to use the intensive dual antibiotics would be more important in somebody who has a really nasty looking ulcer, and you know they will need to be taking this overnight as well. So it's better to just admit them to the hospital, get these drops in the hospital, so that the patient at least doesn't have to worry about waking up at night every hour or every half an hour to try and put those drops in. And 3 things that you have to do anyways as well. Number 1, stop them from wearing the contact lenses until this whole situation is over and the eye has completely healed. Number 2, do not cover the eye, because the eye will become an incubator for infection. Let it breathe. Keep the eye open. Do not put a patch on. Cycloplegic eye drops like cyclopentolate or atropine can be also used to ease photophobia and prevent synechia formation in the eye. Now remember, when she came into your clinic, she was flinching quite a lot away from the light. That was photophobia. That was the light sensitivity. The cornea is the most densely innervated tissue in your entire body. So when its surface is breached and the eye is inflamed, light and ciliary spasm cause a lot of agony for the patient. So have a look at this picture. This picture is of a mouse's corneal nerves. You can see how densely innervated the cornea is. And so this fact then hands you one of the most useful bedside signs in corneal infection. If the cornea is so densely wired for pain, then pain becomes one of your monitors. When you review a bacterial keratitis the next day, you're not just looking for the ulcer to shrink, because it could be too early to tell. You're asking one question: does it hurt less? Is it feeling a bit better? Decreased pain is one of the earliest and one of the most reliable signs that treatment is working, combined with your examination to make sure that the ulcer is not getting worse or it hasn't perforated. This can often reassure you. And the reverse is also true. An ulcer which keeps getting more and more painful, or simply not getting better, despite your intensive eye drops and antibiotics, do not reassure yourself. That could mean that the eye is telling you something's definitely wrong. Well, there could be a few things that could be going wrong. 1, the patient is not as compliant as you would like them to be. The toxicity of the drug could be a reason, or that it was not bacterial to begin with at all. It could be one of the other infections that we spoke about: fungal, Acanthamoeba, wearing a bacterial mask. So when the pain is becoming worse, or the eye is not settling down as well, you need to think of a few other things to ensure that you're not missing something important. And so here's what I want you walking out with. The next time patient like the patient that you just encountered comes to your clinic, a contact lens wearer with what looks like could be a simple corneal abrasion, I want you to think about bacterial ulcer and the causes that I mentioned to you earlier, especially if it looks like there is an infiltrate as well. Do not patch the eye, get them to stop wearing the contact lenses, and instill the treatment even though you have sent away investigation. Once the investigations come back, you can further tailor your treatment according to the sensitivity provided to you using your scrape. But do not ever delay treatment waiting for the corneal scrape. That's all for today. I hope you found that discussion about bacterial keratitis useful. If you would like me to discuss any other topics in ophthalmology, make sure to leave them down in the comment section below. Follow me for more of these case discussions, and I will see you in the next video.